To cool or not to cool? That is the question. In babies with possible HIE or poor cord gases, it can feel like a really tough decision, as unnecessary cooling will be extremely invasive for the baby and can lead to medical complications, but equally withholding cooling can lead to fears that a future cerebral palsy diagnosis will lead to your management being questioned. Whilst there are no easy answers to these issues, in this video we will learn all about neonatal HIE, clinical assessment and neonatal neurological examination and cooling criteria. I'm Dr. Matthew Sayers, a consultant paediatrician with over 10 years experience in paediatrics, and I have treated a number of babies with neonatal HIE, both in the neonatal period and subsequently with epilepsy and developmental delay. In this video, I will share my tips and techniques on how to assess a baby with potential HIE. Links to all guidelines and documents are available in the video description and also on the OLAS medical app. Hypoxic-Ischemic Encephalopathy is a condition in which the baby's brain and other organs are starved of oxygen due to an hypoxic event at the time of birth. This leads to neurological impairment in the form of reduced level of consciousness, poor tone and seizures, which can persist, causing permanent brain damage with developmental delay, cerebral palsy and epilepsy. Various studies, including the TOBY trial, have demonstrated that initiating whole-body cooling of a newborn with moderate or severe HIE for 72 hours significantly reduces the combined outcome of mortality and neurodevelopmental disability at 18 months of age. Cooling is performed in a neonatal intensive care unit with specialist cooling blankets and rectal thermometers, and the baby must be closely monitored while this goes on. In this video, we will consider the case of a 39-week gestation baby born by normal vaginal delivery. There was shoulder dystocia at delivery with entrapment for 6 minutes. When the baby was born, they were pale, floppy and apneic and had a heart rate of less than 60. But after 5 inflation breaths, regular breathing was established and the heart rate is now greater than 100. They remain very floppy and quiet, and the midwife has asked you to review them. Their birth weight is 4.5 kilograms and their cord gases show a pH of 6.9 and a base excess of -20 and a pH of 7.2, base excess -15. In order to commence therapeutic cooling, the baby must be over 36 weeks gestation and must be less than 6 hours old. There are then 3 additional criteria that must be met. Criteria A deals with the hypoxic-ischemic element, and there are a number of clinical and investigation factors that can increase the likelihood of an hypoxic-ischemic insult occurring at delivery. Criteria B consists of the clinical assessment of encephalopathy. The baby must have reduced alertness as well as one of altered reflexes, reduced tone, reduced suck or seizures to meet criteria B. Criteria C uses cerebral function analysis monitoring to make an amplified EEG diagnosis of encephalopathy. We will examine all 3 of these criteria in detail in this video. Babies should be greater than 36 weeks gestation, greater than 1800 grams, and less than 6 hours old to meet criteria for cooling. It should not be performed if the baby has other major congenital abnormalities, a significant skull fracture, life-threatening hemorrhage, or if death appears inevitable. If you're unsure about any of these, discuss with a senior neonatologist. We firstly need to consider if the baby has features in keeping with a perinatal hypoxic-ischemic event. We will consider clinical features and blood gas features, and I'll summarise these below. If there is an APGAR score of 5 or less, or an ongoing need for resuscitation at 10 minutes of life, or if there is a pH less than 7 or a base deficit of 16 or more on any blood gas within 60 minutes of birth. In this case, we can see that the baby does meet criteria A for cooling as their blood gas is less than 7 and their base deficit is greater than 16. Now that you have completed your assessment of criteria A, you can now move on to criteria B. Criteria B consists of a clinical assessment of encephalopathy, and we will look at this in depth in this video. To meet criteria B, the baby must have reduced alertness, as well as one of altered reflexes, reduced tone, reduced suck, or seizures to meet criteria B. It can be helpful to adopt a top-to-toe approach, which can be integrated into the general systemic examination of a newborn. Note that these clinical features identify general neonatal encephalopathy, But hypoxic-Ischemic encephalopathy is not the only form of encephalopathy. Other forms of encephalopathy, such as metabolic, epileptic, or uremic, can occur. Firstly, examine the baby's level of responsiveness and activity. Normally, babies will be alert or will waken easily. Babies that are lethargic or unconscious and do not waken easily when examined may have encephalopathy. Examine the baby's eyes. What size are the pupils and are they reactive to light? Constricted, dilated, or unreactive pupils may indicate encephalopathy. Move the baby's head from side to side and examine pupil movement. Normally the eyes should follow the direction of head movement. Doll's eyes pupils move opposite to the direction of head movement, and this indicates severe encephalopathy. Examine the suck. Place your finger into the baby's mouth and assess the degree of suck. A weak or absent suck may indicate encephalopathy. Also assess tonic neck reflex. When moving the head to one side, the ipsilateral arm and leg will extend and the contralateral arm and leg will flex, producing a fencing position. A very pronounced or absent response can indicate encephalopathy. Listen to the heart and lungs and review the baby's observations. Bradycardia, irregular respirations, or apnea and excessive secretions may be indicators of encephalopathy. Now we will assess neuromuscular control. Examine the posture of the baby's arms and legs and look for spontaneous movements. Normally these should be flexed with good tone and normal spontaneous movements. If the baby is excessively flexed and stiff or very floppy with limbs extended in a frog's legs position, this may indicate encephalopathy. Hold the baby by both wrists and gently lift upwards into a sitting position, observing the head, neck and shoulders. Normally the baby should have good tone in the neck and shoulders with mild head lag if any. If the tone is very stiff or if there is significant head lag, this can indicate encephalopathy. Now hold the baby under both arms in their axilla and get a sense of their central tone. Normally it should be easy to hold the baby in this posture. If they are sliding through your hands, this can indicate low tone and encephalopathy. Hold the baby in ventral suspension. Normally the baby should have a relatively straight back with the head in line with the body. If the back significantly curves over your hand with the head and limbs hanging downwards, this can indicate low tone and encephalopathy. Check the Moro reflex. Hold your hand below the infant's shoulders and suddenly bring your hand downwards, simulating a fall. A normal response will see the baby symmetrically abduct both arms, followed by rapid adduction. If the baby shows prolonged abduction without adduction or no response, this can indicate encephalopathy. Check the knee-jerk reflexes. Very brisk reflexes can indicate encephalopathy. Remember, upgoing planters is normal in a newborn baby. If there is a very asymmetric response to your Moro and knee reflexes, this can indicate a focal lesion, either of the central or peripheral nervous system, more than encephalopathy. In a very alert and visually interactive baby with severe central and peripheral floppiness, weakness, and absent peripheral and central reflex, this is likely to be due to a neuromuscular disorder, and these babies should be discussed with neurology. Now that you have completed your clinical assessment, you can compare your findings to the Sarnat scoring system, a scoring system to grade the severity of encephalopathy. As we mentioned, to meet criteria for cooling, the baby must have reduced alertness, as well as at least one of altered reflexes, reduced tone, reduced suck, or seizures. In this case, the baby was lethargic and sleeping. They had reduced central tone with reasonable peripheral tone. They had an absent suck and brisk knee-jerk reflexes. They would therefore have met criteria B. In some units, the decision for cooling is made on clinical grounds alone, and we would commence it for this baby at this stage. Others use a period of CFAM monitoring to confirm the presence of encephalopathy. We will look at CFAM in another video linked at the end of this one. A baby who is being cooled should be restricted to 40 mL per kilogram per day. It is good practice to have a UVC and UAC in place, as venipuncture is extremely difficult in a cold baby. Analgesia should be given, for example, a morphine IV infusion to reduce distress and shivering. They should be cooled for a period of 72 hours, and then slowly rewarmed. An MRI scan should be done around day 7 to 10 of life to look for any ischemic changes. Cooling has some complications that you should be aware of. It can cause hypotension, bradycardia and arrhythmias. It can worsen respiratory distress syndrome and reduce oxygen delivery at the tissues. There is an increased risk of sepsis, electrolyte disturbance and coagulopathy. These patients need to be closely monitored with regular blood testing, blood gases and blood pressure monitoring. Also remember that it is not just the brain that takes hypoxic damage in HIE, and acute kidney injury, acute liver injury and adrenal insufficiency are common after severe HIE. How can you explain cooling to parents? You should explain that it consists of a cooling mat, an internal thermometer which reduce the baby's core temperature to help reduce the inflammation in their brain after short of oxygen at delivery. There is evidence that this can improve the brain's healing and the child's later development. Advise that it will last at least 72 hours and then the baby will be slowly rewarmed and all the equipment removed. The baby may need to have a breathing tube and central lines in during the period of cooling to closely monitor and support them. Explain that CFAM measures the baby's brain activity and helps us to pick up abnormal electrical activity early so that we can treat any seizures that develop. Thanks so much for watching. Please like this video, comment with any clinical questions or feedback you have, and subscribe to the channel and our other social media accounts including Instagram, Twitter, Medall and OLAS to stay up to date with future videos. I look forward to seeing you again soon.